Good afternoon, everyone. The panelists are dropping in, and so are the attendees. We're just going to wait till all the attendees are here, or the number sort of stabilizes. And generally, this takes a few minutes. So we just wait for this. And this last webinar, the webinar series. Okay. All right. I think we're just gonna start off with the webinar today. So hi everyone, good afternoon. We are the Disability Study Group of the British Sociological Association. On your screen, you should see Sarah Wooden, who's also co-convener. My name is G. Huig. I'm the other co-convener and organizer of this webinar series. So this webinar series is called Disability and Health Inequalities in Times of COVID-19, and this is the 5th and also the last webinar in the series. We can't actually see you from this side of Zoom, but I hope you're all comfortable enough, and I want to thank you for attending this webinar and perhaps previous webinars as well. Just a sort of heads up, even though our Zoom skills are definitely improving compared to the first webinar, I still hope for your understanding and patience in advance in case there will be any technological or human glitches during the webinar. Just before I introduce the presentations and the presenters, just so you know that the second presentation will most probably already have captions through Google Slides. The first presentation doesn't have live captions, so you will receive the transcript in the chat box. Now, if you don't want to receive pop-ups from the chat box over the screen, and you don't, then you can do the following. You can click on the chat so that it appears as a small pop-out screen. Alternatively, if you click on the chat and it appears on the right, you can go to the left top, and there should be an arrow where you can make it pop out. You can then make it smaller and larger. You can move this pop-out screen to wherever you want on the screen so that either you can see it or so that it doesn't bother you. So hopefully this solves some of the issues with chat messages that pop over the slides. A small reminder that this webinar is being recorded and it will be available soon on the YouTube channel of the British Sociological Association, the BSA. Actually, the last 4 webinar recordings have already been uploaded, in case you want to have a look. Those of you who have opted in for receiving communications from the BSA will receive an email after the last webinar, this one. The recording is uploaded, and this will include a link to the archive of all the recordings on the Disability Study Group's webpage, on the website of the BSA. So you can go through them. This link is quite long, so what I will do now is give you the link to the YouTube channel of the British Sociological Association, so you can already see the 4 previous webinars. The link is youtube.com/user/BRITSOCI, Britsoci. So BRITSOCI. So today's webinar is the second one on intersectional inequalities, again, the last one of the series. And we have 2 presentations today. And what we will do today is have 1 presentation and then questions, and then the other presentation and then questions. However, different from an in-person seminar, you don't actually have to wait with asking your question, because here at the bottom of your screen, at least using Windows, if you hover with your mouse, you should be able to have a Q&A box, and in this Q&A box you can ask your question. And after each presentation, we will pull up all your questions and then ask the presenters, okay? So you can actually ask questions during the presentation. So the presentations that you will listen to today are first from Sarah Jama from the Disability Justice Network of Ontario and Chavon Niles from the Ontario Council of Agencies Serving Immigrants. And it was prepared together with Susan Mahipaul, Karen Yoshida, and Fudge Schormans, respectively a disability and health navigator consultant, the University of Toronto, and from McMaster University. Their presentation is titled Health Inequities and the Invisibility of Newcomers with Disabilities in COVID-19 in Canada. The second presentation, so these are swapped actually from the invite. The second presentation is from Jessi Parrott, who's an independent researcher, and her presentation is called The Paradox of Pain and Peace. So we will start with the first presentation, Health Inequities and the Invisibility of Newcomers with Disabilities in COVID-19 in Canada, presented by Chavon Niles. And I think Chavon, you will present this, right? Yes, excellent. All right, so there will be captions. Chavon will present this alone. So there won't be any input in the chat box, but Chavon will present them on through Google Slides. Do you want to share your screen, Chavon? Do you want to maybe make yourself visible very briefly?
Yes. Hi.
Yes.
Hi, everyone.
Okay, we can hear you well.
Great. I was going to ask, can you hear me and can you see me?
Yes, we can see and hear you.
Okay, wonderful. So thank you very much to BSA for inviting us to be part of this series and help to conclude this phenomenal series that you folks have been putting together. So my name is Chavon Niles, and I'm the Senior Coordinator of the Accessibility Initiative at OCAS. OCAS is the Ontario Council of Agencies Serving Immigrants. As mentioned earlier, this webinar was put together with Sarah Jama, the co-founder of Disability Justice Network of Ontario, which is based out of Hamilton, Ontario, Canada. Susan Mahipaul, Disability and Health Navigator and Consultant. Karen Yoshida, University of Toronto, and Fudge Schormans, McMaster University. Together, we are part of a new network in Canada called Mobilizing Disability Studies Scholarship in the Academy. Group members are those who are teaching or wish to teach disability studies scholarship in non-disability studies academic spaces. The title of this presentation, once again, is Health Inequities and the Invisibility of Newcomers with Disabilities in COVID-19 in Canada. In this presentation, we will be discussing the following. We're going to provide a very brief overview of Canada's Immigration and Refugee Protection Act. We'll speak to the experiences of disabled newcomers. We're going to share what we believe a communication strategy should look like and beyond, and we will share our team contact information. So there is a presumption that the Canadian nation state is welcoming to all. However, Canada's historical treatment of racialized, disabled, and racialized disabled people reveals ableist and racist ideologies inherited from the European understanding of race and disability, which has been embedded in the Immigration and Refugee Protection Act. In 1869, Canada's first Immigration Act, entitled An Act Respecting Immigration and Immigrants, set out to recruit white Anglo-Saxon, quote-unquote, healthy individuals willing to work and build a new home and a new country for themselves and their families. The 1906 Immigration Act included a stricter and a specific list of conditions for the exclusion of specific applicants and outlined conditions under which a person could be deported. Canada removed the overt racist policies that prevented the immigration of racialized people, eventually being amended, opening doors to people from non-Western countries in 1976. The Immigration and Refugee Protection Act of 2002 does not overtly list disability as a prohibited ground. Rather, the language of the Act spoke only of the excessive demand some applicants might place on Canada's health and social services. On June 1st, 2018, the federal government created a temporary public policy regarding excessive demand on health and social services. This public policy allows officers to exempt individuals who have fallen under the excessive demand category. Audre Lorde said, "There's no such thing as a single issue struggle because we do not live single issue lives." As highlighted through the slides on the Immigration Act, race and disability are intimately connected with significant consequences for disabled racialized people. Yet racism and ableism are often thought of, talked about, and presented as, quote, parallel system of oppression that work separately to perpetuate social hierarchy, end quote. In doing so, we fail to question, critique how race is pathologized to create and maintain racism and ableism. People with disabilities make up some of the largest demographics in the world, where 25% of the world population is disabled. They're part of every race, every religion, geographical location, every identity on the LGBTQIA++ spectrum. Aging is also a leading cause of disability. It is no surprise then that there are many immigrants, refugees, including newcomers, with visible and invisible disabilities. While difficult, immigrants with disabilities do find their way into Canada, while others may acquire or develop a disability while they're in Canada or have a disabled child. We may not hear a lot about disabled immigrants because they may be unable to access the limited and often inaccessible programs and services in the community. There is an image on the screen which I'm going to take some time to describe. So on this slide, we have a diagram with a circular arrow. On the circular arrow, we have 8 circles. 6 circles are in blue and 2 circles are in purple. White text appears in each small circle. Each circle has a straight arrow pointing to the center of the slide, where a graphic of 2 faceless people appear in black with a question mark above one person's head. For this presentation, we will be highlighting the barriers in purple. Some of the barriers we hear the most about as it relates to the experiences of newcomers with disabilities in Canada is fear of deportation. Briefly, I went over the Immigration and Refugee Protection Act, and what we also find is that that fear of deportation leads to a reluctance or a fear of accessing the limited social and health services that disabled newcomers do need. What we also find is that there are a lot of gaps between immigrant settlement services and disability-specific services and other essential services. Many times, health and social service organizations continue to work in silos where folks have to leave a part of themselves at the door. Their limited or their lack of community-based resources, especially culturally and linguistically appropriate health, social, and educational services available. Service providers also lack awareness on how to support newcomers with disabilities. And we find that there's not enough recruitment and outreach directed towards immigrants with disabilities. Many disabled newcomers struggle with how to navigate all areas of life in Canada and may not feel it is appropriate to ask questions to people in positions of power. Like many countries around the world, when the realities of COVID-19 became clear, the Government of Canada required people to shelter in place. However, this request failed to consider the compounded barriers disabled people experience. Some of these barriers are exacerbated for newcomers with disabilities who've been left out of the conversation. We will highlight some of these barriers in the next slide. Essential services. For the purposes of the Essential Services Act in Canada, a service is essential if it consists of any of the following: the production, supply, or distribution of any form of energy, power or fuel or energy, power or fuel resources, the provision of public health services, including hospitals or medical services. The Government of Canada decided what essential services are across the country. Some services that were once used by disabled people are not deemed essential, with no plan put in place to support disabled people who are left in limbo. Moreover, the unique challenges disabled newcomers experience was not even considered. An example we have includes that of a person by the name of Janelle. She is a Black disabled immigrant woman with a congenital disability and autoimmune disease. As the realities of COVID-19 set in, Janelle was waiting to be refitted for her new leg, which COVID-19 put on hold as it was not deemed an essential services. And Janelle says, quote, "I do not live my whole existence as a disabled person only. I'm a disabled Black woman, you know, where all of that works in tandem with each other. And it's almost as if because like people are only focusing on a single story, I have to choose between either my Blackness or my disability. I do not move in life like that. It is really important to highlight a holistic experience because there are multiple things going on at the same time as I move through life. The system does not focus on just one thing. These structures are very violent and they affect each and every one of my identities." Janelle asked us to consider what would happen to her if there was an emergency. In Canada, in Ontario, Canada specifically, there was a COVID-19 triage protocol that was put in place. And this is the province that we live in. So the province created a triage on COVID-19 protocol. The protocol exposed a disproportionate and adverse impact it would have on people with disabilities. This reinforces the notion that disabled people are disposable, last in line for supports based on discriminatory practice. Arch Disability Law Clinic put out a petition against the protocol where it was rescinded. Recently, a similar protocol has been put in place, showing us that nothing has changed regarding the valuing the lives of disabled people. Gender-based violence and shelters. There has been an increase in gender-based violence since the onset of COVID-19, with many being forced to stay at home. However, for those who are seeking shelters, many remain inaccessible for disabled people, let alone disabled newcomers, given language and cultural barriers. Moreover, with many services moving online, community workers are unable to connect with these service users. Given the protocols to stay at home, disabled people, including newcomers, in public spaces are being assumed to be intentionally breaking the law, with some being fined. There needs to be some understanding that people need to be in public spaces for different reasons. For example, health and safety reasons. I've highlighted some already. We believe there is a need to reimagine what an accessible and an inclusive communication strategy can look like. An intersectional approach, coined by Kimberly Crenshaw and further developed by Patricia Hill Collins, would enable the government to have a greater understanding of how COVID-19 is impacting the diversity of people in Canada. However, communication is only the beginning. All levels of government, as well as health and social service agencies, can benefit from developing an inclusive and an accessible communication strategy. This starts by ensuring government is working with community members to better understand what their needs are and find strategies to better support them. Communities rely on interdependent mutual aid, such as support with getting groceries, picking up medication, running errands, etc. Deaf-blind individuals require persons within their personal space to interact with their environment. Deaf and hard of hearing people cannot communicate and or understand others while wearing a mask. As we begin to think about recovery and what that entails, we believe the government and community at large needs to connect with the most vulnerable in developing recovery plans. Co-create immediate, short, and long-term recovery plans that take into consideration attitudinal, information and communication, technological, and environmental barriers, for example. This slide includes our references. The road ahead is not an easy one, but we can create a more just society that benefits all of us. Thank you very, very much.
Many thanks. Many thanks, Chavon. And all the others, of course, for preparing together. Excellent presentation. Yes, when I was listening to your presentation, I noticed, unsurprisingly, I suppose, but so many similarities, I suppose, here in the UK, and that we hear from other countries in a way as well, like intersectional complexities around race, disability, and sort of health in a kind of like broader sense, and well, poverty, if you will, as well. And it's kind of like how to interact with each other, isn't it, in the personal and the public sphere, and how all of that sort of comes together or impacts as these compounding barriers. Yeah. I was wondering if anyone in the audience has any questions or would like to ask any questions, which you can ask in the Q&A, so we can read them out loud. Okay. Well, I'm just going to take the liberty to ask a question, if that's okay. I was wondering, you mentioned interdependence, and I was wondering whether you could say, or one of you could say a little bit more about how you feel that interdependence, well, you mentioned, for example, mutual aid, but how interdependence worked in perhaps a resistance strategy, if you will, and perhaps in other ways as well during this period of lockdown and COVID, or how it is working for the people that you were talking about specifically, or more generally. Maybe someone wants to speak to that.
Who wants to start?
Okay, well, I can start. It's Karen here. Thanks, Chavon, for leading us on that nice presentation. I think when we talk about independence, we can talk at it first in a number of levels, like you mentioned, G, about certainly in an interactive way. First of all, I mean, with COVID-19 and this whole protocol of safe distancing and keeping people away from each other in the lives of disabled people, that doesn't always work. I think Chavon has mentioned a couple examples of people who are deafblind who require an intervener who is working with them to communicate on their hands, whether it's deaf and hard of hearing, people who cannot then read someone's lips, or in communicate in that way, and people who might be living with physical bodily differences who require assistance on a daily basis to help with anything like bathing, getting out of bed. There's an interdependent need for assistance that helps the person get on with their daily lives. So I think, first of all, those types of protocols totally don't even address or ignore, or don't even take into consideration the daily lives of how interdependent daily lives disabled people are with each other, and even non-disabled people as well. People who are in fact wanting to go to the hospital and need to have a partner come with them to help them understand what's going on within their health encounter. And the hospital says only one person can come up to the clinic. And people have to do things like talk on the cell phone. I mean, it really ignores how interdependent we all are in different ways, and especially for perhaps disabled people who have unique interdependent needs and usual needs like everyone else. From a resistance point of view, I think what we're seeing worldwide is hopefully coming together in coalition interaction between different anti-oppression movements. And I see that maybe as not interdependent, but maybe more allyship or coalition building, and that need to do that. And I think it's really great. And hopefully if there's any small little silver lining in this COVID thing, is that different groups realize that they're stronger in working together than working separately, in which a lot of governments try to keep groups from working together by keeping them as special interest groups. So anyways, that's my take on both your comment. Thank you.
I was wondering if I could add to that, Karen. That was really great. Hi, my name is Susan. I think to add to what Karen was saying, I think for a long time in disability studies, I mean, the concept of care is theoretically a bit tricky, right? And I think from a medical standpoint, people assume that any person with any type of disability or need is always cared for, but that it's not a two-way relationship. And I think the pandemic has really brought forth that the care receivers, if you want to say that. So for example, I'm a person with a disability. I care very much for my caregivers, and it's a two-way relationship. I care for their safety, I care for their health, and they care for my safety and my health. And so it's brought up some very difficult conversations, I think, for many of us in the community as to what's safe. You know, is it safe for me to take care of my caregiver? It might not be safe for me because I need the care. So I think those are conversations we've been having for a long time, but they've been really coming to the forefront during the pandemic. I think other things that, to go back to essential services that Chavon was mentioning, the resistance I find, like I'm a narrative researcher, so I perk up when I hear stories. And, you know, families, for example, who have aging family members in long-term care homes, they've been saying that they should be seen as an essential service. There should have been a way for those homes to find a way to get the families to come in, because they are a crucial part of their loved ones' lives. And so there's a lot of things that happen, and this has been happening globally, I have heard, not just in Canada. But I think that's part of I think the resistance now has a face where we maybe have an opportunity to talk about what care is differently, and that is part of interdependence, because in the neoliberal world that we live in, you know, it's usual the government just pushes everything down onto the family, and so yeah, you stay at home, you're safe at home, close your doors, and then you won't get COVID-19. But you know, behind closed doors, a lot of things have been falling apart for families and their loved ones, because they rely on that interdependence. And those things are, I think, exacerbated for everybody who has a disability. And then when you're looking at newcomers or people who don't have those networks, then that's even experience greater. So it's a big question that you asked, but yeah, that's how I see it.
If I could add just a wee bit as well. Hi, I'm Anne. Some of what's happening as well around some of this is that you have groups of people with disabilities, disability communities, who are kind of coming together and finding ways to say, well, I'm able to do this and you can do that, and I need that and you need this. And so people are supporting each other in those kinds of ways. Like some people who maybe have access to a car or doing groceries for a whole bunch of people. There's other people kind of setting up phone trees, so to keep in touch with people, to make sure people aren't all by themselves, because a number of people don't have access to technology, like to computers and Zoom and things like that. So some of that's also happening on the ground, right? But that's not necessarily easy, and it can really take its toll on people as well, right? It can be quite exhausting. So.
Thank you. I was also wondering, before we go to the questions in the Q&A, maybe Chavon, you want to speak to this a little bit, how race and racism sort of impacts or plays a role in this?
Well, I think it plays a big role in this, because when people think of Canada, they think of Canada as a welcoming nation. They don't think about the ways in which race and disability are intimately connected with each other. Even though there has been changes in the Immigration and Refugee Protection Act and removing the overt racism is still embedded through the point category, for example. And when it comes to being racialized and disabled, we have to look back at the disability rights movement, how it started, who was included and who was not included. And that's why we see this second wave. That's what disability justice scholars are calling it, being led by Black, Indigenous people of color who are queer. So I think that it's really important for us to also understand that when health and social services are created, they're created with a specific archetype, a specific individual in mind. And in many ways, that makes it even more difficult for racialized disabled newcomers to access these services, these very limited services that are created, that are still very much grounded within a medical model understanding of disability.
Thank you. Yeah, I was also wondering about something you mentioned earlier about basically being outside on the street, either as a disabled person of color or someone who does care work or something else relevant to, well, living basically of color on the street, and how that impacts, I don't know, the role of that. There are two questions in the Q&A, both really interesting. So I'm just going to start with the first. Stephanie Harvey asks, I note that ambivalence regarding intersectionality in the Equality Act 2010, which is British, is replicated in public health policy, where multiple disadvantage is spoken of without acknowledgement of intersectionality. Is this similar in Canada? Unfortunately, the UN CRPD committee's interest in this area does not seem to be reflected in government. Do you think this is in part due to a fear of the complexity inherent in intersectionality?
That's a really great question. So we don't have an Equality Act, and team, please correct me if I'm wrong, but we have the Canadian Charter of Rights and Freedom, which is Canada-wide, the Ontario Human Rights Code. And while the Charter of Rights and Freedom, I believe it's section 15.1, that speaks to the fact that you cannot discriminate against somebody based on their race, their class, their gender, their creed, etc., they're all presented as separate identities, right? And I do believe that, I'm not sure if it's the government not wanting to admit that people are complex, or not having that awareness that I could be multiply marginalized. I have multiple identities. And so the barriers I experiences are compounded, as well as just being a single issue that, that I'm experiencing. But I do see slowly there are conversations happening. That's why we wanted to partner with Disability Justice Network Ontario, because they're a grassroots organization that are specifically using a disability justice model in the programs that they are putting forward, to also help us understand the importance of interdependence, and moving us away from thinking that we live independent lives, because we really don't. Anyone else would like to add?
So it's Karen here. Yeah, I agree with what Chavon has said. I think the understanding, and certainly we'll just speak to the issue from a Canadian point of view with the charter, is that I agree that it's not really clear that people really understand what intersectionality really means, and how all these different social positions that people might hold or are constructed are all sort of mutually constituted. And so you really can't separate them out, even though the language is of always talking about them as separate categories. I don't think there is language that talks about the multifaceted, how multifaceted they are, and how they in fact are sort of co-constituted with each other. I don't think that kind of level of understanding is kind of exhibited in these policies, and I think there's lots of misunderstandings from that point of view. So yeah, I agree with Chavon. I think there needs to be continually to push for that kind of deeper understanding of what intersectionality is. And you're right, I think the government could be quite fearful about even taking that on, because it really does have incredible implications for what that means for how we structure society, how we structure many of our services, etc. So, yeah.
Thank you. I also think it's important to sort of like think about how intersectionality in a way also points to privilege, isn't it? And that might be threatening as well. Deepak has a question. To what extent do you think disability services access is self-policed by the most vulnerable through the stigma of asking for help and assistance? The stigma being embedded within the very communities that are supposed to help and receive people, then compounded and affirmed by wider settler communities' views of newcomers. Settled communities' views of newcomers. So to what extent do you think disability serves as access is self-policed by the most vulnerable through the stigma of asking for help and assistance?
That's a great question. It's a hard one. I'm thinking of Bell Hooks, the feminist Black scholar. And one thing that stuck with me as I was doing my PhD work was that because I was born with my disability, I'm an occupational therapist. And so I had to ask myself the question, was I myself becoming the very people that have oppressed me my whole life? And Bell Hooks talks about that a little bit in her writing. And I don't have an answer to that, but I think the question is a good one because I think there may be some truth to it. It takes a great amount of reflexivity to be able to talk about it. And then just on a personal note, being in an interracial marriage where my husband is brown and from an immigrant family, they talk about too how they when they immigrated, they did everything themselves. They didn't ask for help. And so they can have sometimes very interesting views of newcomers that I listen to because I think those are perspectives. And I don't know about policing, I don't know, but I think it definitely could add to the fear of asking for help and the fear of, or the driven nature to prove that you can do it on your own, and perhaps that then puts you into a role of a, dare I say, super crip, or I'm not as disabled as I am, or I'm going to pass, or I'm going to hide, where it gets you into all of these other. I may be totally off with the answer here, but that's what I was thinking about with the question, because it's an interesting one.
Thank you. I was also wondering specifically how immigration or having refugee status or somewhere in between that impacts this self-policing. I was wondering, Chavon, whether you've noticed something around that.
That's a really
specifically
great question.
Thinking about COVID-19.
Yeah. From what I see, and I work for an organization that supports the immigrant and refugee sector across the province. And so we provide training focused on how to support our membership better understand and respond to the needs of newcomers with disabilities. And one of the biggest thing we find is, one, people do struggle to take up the disability label because of the negativity that is attached to the label itself. Your status does impact what you have access to. If the disability is invisible, some folks are reluctant to come out as being disabled to seek the supports because they are very afraid of being deported. And if you think about it, it wasn't until 2018 of June that the Immigration and Refugee Protection Act, that part around excessive demand, there was a slight amendment that was put in place. So the law has a lot to do with how people choose to identify and what people choose to access. And whenever I have this conversation, I'm always asked, like, how do people know? Like, because they know. Folks know. They read the law. They understand the law. They probably had to go through a medical exam before they come here. And there is also this notion, this idea that I should be thankful that Canada took me in, so I don't want to appear as though I'm taking from the system. And if I speak to the barriers and the challenges I'm experiencing, then I'm a bad immigrant. And what we try to do is we try to say, no, you're not. These are supports you need so that you can have a better quality of life.
Thank you. I suppose this is one of these topics that hopefully research will sort of come up and emerge more in terms of what the impact has been and what the impact still is in terms of how immigrant and refugees, I think generally racialized folk in Canada, but also in the UK, are disadvantaged disproportionately, including death. Yeah. Okay, just very briefly, one more question from Anishta. Your study looks at newcomers. I was wondering if you have or thought of comparing their racialized experiences to ableism in the context of settler colonialism.
That's a good question. And it probably will be something we would want to look into as a team going forward. But as of right now, no, very honestly, I wasn't thinking about that, but thank you for bringing that up.
Thank you. Yeah, and I think it's also a question that when we think about what is being exported from Europe with settler colonialism in terms of racialized ableism or ableist racism. Yeah. I'm afraid we don't have time for any more questions. My apologies to the rest who've asked any more questions. To the team, do you have any last comment that you would like to share before we go to Jessi's presentation?
I don't know if you have comments, but just thank you so much for this space. It would be wonderful if the questions that folks have, if it could be shared with us, because I think as a team, this is something we might want to think about and think through as we move forward. Our contact information is available in the slides. So if you would ever like to reach out to us, please feel free to do so. And thank you so much again for inviting us to be in conversation with you today.
Thank you, and hopefully we can organize at some point something else around teaching disability studies. Email I still haven't responded to, but will. Thank you so much.
We'll contact you.
Excellent, excellent. Jessi, are you?
Yep, all set.
You're there, excellent. So if everyone else wants to stop their video. Thank you.
If it's okay, I'll leave my video off still because
yes.
The internet.
That's fine. Give me 1 second before I don't accidentally. Okay. Sorry, I have to get everything set here. My apologies. All right, I'm going to share my screen now, and then I will mute myself and stop my own video. And, okay. You ready, Jessi?
Yeah,
okay.
Great. So, hello everyone, I'm Jessi Parrott, and I'm a performer and early career researcher. My presentation title is The Paradox of Pain and Peace. Before I get into what that means, I'll briefly audio describe myself, especially as I'm off video, for anyone who might find that useful. I'm a white woman in my late 20s. I have shortish brown hair, although it's got longer during lockdown, and brown eyes. I'm wearing a dark green top and sitting in my powered wheelchair. If we could go to slide 2, please. Great. Thank you. So this is an activist academic exploration of life as a queer disabled woman during the COVID-19 pandemic. It's a personal perspective situated alongside academic content in an attempt to make sense of the myriad physical, emotional, and political implications of this unprecedented, in quotation marks, time. This presentation grew up during lockdown, and the ways in which my existence as a bisexual woman with cerebral palsy and a powered wheelchair user has had both negative and positive consequences during the global pandemic. As I'm an actor and activist as well as an academic, I've considered it a particularly personal form of practice as research. Next slide, please. Slide 3, sorry, Dee. Thank you. Central models and concepts. So there's the social model, Mike Oliver, 1990, and others. The political relational model, Alison Kafer, 2013. The embodied ontological model, which is Tom Shakespeare and Nick Watson, 2002, and Shakespeare, 2014. The models I'm referencing are the social model, where disability is a result of barriers in society, and the political/relational and embodied ontological models. To also observe the origins of disability that are social, but additionally give space to the significance of impairment effects, cf. Carol Thomas, 1999, such as chronic pain and fatigue. I've not made reference to the medical or individual model, although much of the rhetoric around vulnerability in this health crisis. The central concepts and their significance are defined in the following slides, but it felt important to list them here first. Slide 4, please. So, forced intimacy versus access intimacy. These are concepts articulated by Mingus in blog posts from 2011 and 2017. Forced intimacy refers to the daily personal parts of ourselves to survive in an ableist world. This often takes the form of being expected to share very personal information with able-bodied people, her words, to get basic access, but it also includes forced physical intimacy, especially for those of us who need physical help that often requires touching of our bodies. Access intimacy, by contrast, is that elusive, hard to describe feeling when someone else gets your access. Solidarity shared, many at the table who have an lived experience of the many different ways ableism manifests in our lives. I'm in a conducive and otherwise in a contradictory way. My access needs requiring significant personal contact at the moment, when social distancing is advised, means that even the most caring and supportive engagement can feel like forced intimacy of physical contact, which means that I am not touch-starved. Slide 5, please. Compulsory able-bodiedness and able-mindedness. Compulsory able-bodiedness was formulated as a concept of Adrian Rich's compulsory heterosexuality, which is defined on the next slide, capable of the normal physical exertions required in a particular system of labour. From this, he argues that compulsory able-bodiedness functions by covering over with the appearance of choice, a system in which there actually is no choice. Compulsory able-mindedness is a further extension of this by Alison Kafer, 2013, to encompass the fact that norms dictate responses to mental or cognitive difference as well as to physicality. During a global health crisis, there is much emphasis, of course, on health. This means that ideals of ability, both physical and cognitive, as well as social, are particularly paramount in both. It also means that these distinctions of consequence, disabled people are potentially powerful guides, given that we navigate uncertain terrain on a day-to-day basis. Slide 6, please. Compulsory heterosexuality. Adrian Rich, 1980 to 86, observes the bias of compulsory heterosexuality through which lesbian experience is perceived on a scale ranging from deviant to abhorrent, or simply rendered invisible. I refer to her because they were McCrua's inspiration. However, A, there is no acknowledgement of the validity of bisexual identities, and B, disability is used as a metaphor for women's subjugation instead of addressing the lived experience of disabled people. The reason that I bring this original concept up, beyond to place a caveat on my use of it, is that the necessary cancellation of pride parades has removed my one guaranteed expression of my queer identity in a public yet anonymous sphere that does not require. As a wheelchair user, many of the community venues are physically inaccessible to me. Sorry, I think I cut off. I'm hopefully
Jessi,
back
can you hear me?
now.
You
But
cut off.
yeah, I'll go. Yeah, can you hear me?
Yeah,
Am I back now?
you are back
which
now?
bit did I cut off at?
You are
Great.
at, however, the cancellation of what is of course a protest. On slide 6, the end. Yeah.
However, thank you. However, the cancellation of what is of course a protest also invokes my understanding of the significance of Black members of the community to the beginning of the Pride movement, and my consequent wish to be able to support my Black queer siblings, in particular in the Black Lives Matter movement, as an ally. It has been difficult to reconcile my inability to engage with social gatherings with the concern that social media activism might be considered performative. Slide 7, please. As a penultimate point, I wanted to make a further note on language and self-situation. My decision to self-situate might position me as in adhering to standpoint theory developed by Sandra Harding and others, but I cannot stand independently, so it doesn't fit for me. Similarly, Jen Rinaldi emphasizes the pressure of disclosure around discussed earlier of forced intimacy. I therefore wish to highlight that there are aspects of my experience to which I have not and will not refer. Slide 8, please. Experiential and existential confusion and hope, question mark. While it is difficult to balance these two contrasts, in many ways they are the essential characteristics of life when one is either queer or disabled, or both. In fact, they might even be fundamental to the human condition, regardless of the particularities of one's experience. As a result, the trauma that the current situation has brought forward might also be tempered with a sense of peace in understanding a connection with communities across time and history. Thank you.
Thank you, Jessi, for your presentation. Would you like to give it a try to show your video?
Yeah, I can.
Or even just briefly, perhaps, but maybe that impacts your connection really badly, in which case it's not a good idea. Okay. I have a few
Hello.
questions. I hope everyone, there were some moments that the internet connection broke down a little bit, but I think hopefully everybody was able to follow the presentation together with the transcript in the chat as well. Thank you very much. I was wondering if the audience or anyone in the audience has any questions that they'd like to ask through the Q&A to Jessi, or perhaps any of the other panelists. Let me ask my questions. Let me just see. Yes, I was wondering whether you could say a little bit more about the tension between forced intimacy versus access intimacy when thinking about access to care and the COVID-19 lockdown and isolation. Yes, and I was actually, maybe I'll just put these two questions together. I was wondering whether you could reflect perhaps on the role of whiteness in this.
Whiteness, did you say?
Yes.
Yeah,
you mentioned
absolutely. So I think I'll start with that one because it's something that I've been acutely conscious of recently, particularly as I've been able to technologically participate in a dear friend's anti-racist book club that she's organized. And so what's been really interesting is how we have collectively come together to provide care for each other, but obviously that solidarity is contingent on the internet at the moment. As I mentioned in the presentation, it says my internet connection is unstable, so I'm going to turn my video off.
That's okay.
Hopefully that will help. So that's been really interesting because obviously when you're coming from the perspective of even multiply marginalized groups, it doesn't necessarily mean that you don't experience privilege in other ways. And obviously my white privilege is something that I'm aware of. And then going back to the connection between forced intimacy and access intimacy, and actually I can connect that to whiteness too, because we're based in London, there's a significant amount of stop and search that happens. And so obviously that is a different kind of forced intimacy that people from the Black and mixed race communities near to where I live experience. But yeah, the tension between access intimacy and forced intimacy is an interesting one that I constantly navigate, because even if I consent to a care procedure, that consent is predicated on the fact that I need it to live. And so it's not actually a consent that I really have a choice to give or not. And as I said in the presentation, even the most careful people who are supportive and lovely about it, that then in a time particularly when it's necessary to be socially distant, supposedly for health, then requiring that kind of closeness is particularly difficult to come to terms with. And I said in the presentation that I wasn't going to disclose everything kind of on principle, but I do think one element that is relevant to bring up that I didn't in the presentation is that I have complex post-traumatic stress disorder as the result of engagement with several caregivers, but also as a result of some online engagement when I was younger. And as a result of that, constantly having to be engaging with technology right now to communicate with the outside world is a bit of a difficult one. So the desire to be part of a community, in some ways the internet is great for deaf and disabled people because we do create those kind of communities that are separate and distant. But at the same time, if elements of your experience are triggered by online communication, that then makes it quite difficult. Yeah, I don't know if that answers your question.
Thanks, Jessi. Yeah, I think you bring in a lot of interesting and very important points as well. And I hadn't personally considered technology in that sense as well. So thank you for that. Yes, and I also think it gives a lot of food for thought together with the other presentation as well in terms of how whiteness impacts disabled lives and access to care, access to treatment, access to, and almost access to life, and perhaps even can think about which disabled lives matter in that sense, and matter more or matter less. Yeah.
And actually jumping off from that, something that was touched on slightly in the previous presentation, I think in one of your questions, but quite a few of my PA team are from Black or Asian backgrounds, and so then they are in the groups that are supposedly more vulnerable, and so then we've had to really think about restructuring of my care support at this time, because obviously I don't want them to be vulnerable because of work coming out to work with me, but then I don't necessarily have quite as much care support as I did. So then the people that are working with me are fatigued quicker. You know, there's all sorts of interdependent things to consider, especially when you have a team of multiple people. Yeah.
Thank you, Jessi. Yeah, I think we're coming to a close. I was wondering if are there any other questions or comments, Jessi, from you, from any of the other presenters, or from the audience? Sorry. No? Okay. All right, so well, we reached the end of the webinar series, Disability and Health Inequalities in Times of COVID-19. Sarah, do you want to give your summary?
Sure, I'll just say thank you really from my part. It's been fascinating during this series. It's been fascinating today, and it's been fascinating in every week to hear from a wide range of perspectives on disability and COVID-19. I mean, we do appreciate this. We're in early days, really, in terms of the current situation, and this is really framed as an exploratory discussion of the kinds of things, the issues that are coming up, the sorts of work that's being done, and maybe the kind of research and work that needs to be done. Nevertheless, I suppose just a couple of brief thoughts. Some similar themes have come up across country. This has been great. It's been a very international group of people who've been able to participate simply because we're on Zoom and the practicalities of it. But it has been very international. Nevertheless, some similarities are evident in the themes. Certainly precarity of the situation of disabled people, and this is not just at risk from the disease itself, but situational. issues compounded by issues of intersectionality too. You know, the scrabble for resources and who's at the top of the pile and who's at the bottom. I think we have some way to go with that. But also encouraging to see the range of new initiatives that are coming on board that are led by disabled people and their allies. And this is really encouraging. This is great to see. What else? Also, the other thing I think that's worth saying is that there's been really encouraging diversity of sociological analysis and the approaches taken. There's been everything from statistics to, kind of auto-ethnography and many in between. So that's been great. And clearly there's a lot more to be done. We, as G has said, are part of the Disability Study Group and carrying out these webinars as part of BSA. We would really like to continue our collaboration with people on this. Do keep in touch with us. Details are on the BSA website, and the BSA study group is listed on there, and our addresses are on the website. We hope to organise future events. Maybe in a year's time, we might have an opportunity to look back or even beyond that and pick up some of the themes that have been developed and look at some new ones too. And we hope that in that process, we'll be able to continue to work with you. So it's been great. Thank you. Thank you very much from my point of view. And I'll hand over to G for some final words.
Thank you, Sarah. Thank you as well. Yes, so last, I want to thank in this webinar, Sarah Jama, Chavon Niles, Susan Mahipaul, Karen Yoshida, Anna Fudge Schormans, and Jessi Parrott. And this is the end of the webinar series, Disability and Health Inequalities in Times of COVID-19. As mentioned, you will be able to find the webinar recordings on the YouTube channel of the BSA. And since you have attended this webinar, you will receive an email with the link. The link is youtube.com/user/BritSocky with a C. And the last 4 webinars the recordings have already been uploaded, and presumably this one will go online shortly as well. I will hand over the co-convener baton next month. I am though running 2 international online reading groups, one on disability and feminism with Kelsey Acton and one on neurodiversity. If you Google neurodiversity reading group, you should be able to find us hopefully, and feel free to join. I hope you have enjoyed the webinars. I definitely did. And I hope that our paths may cross again in the future at some point. And yes, thank you everyone. And I hope you have a great evening or afternoon, depending on where you are. Bye, everyone.
Bye. Thank you, Guy.
Thanks a lot. Bye.
Thanks, everybody.
Bye.
Bye.
Thank you. Bye.
Bye-bye.